So, welcome everybody. This is something we're trying out, so your feedback will be important to us afterwards. Let us know how you think it went. But in the past, we've done these town halls with a few hundred people in big auditorium, and we did 3 in the same day, and sometimes we did 3 one day and 2 the next. So trying to get a smaller groups meeting, me meeting with several small groups to allow more back and forth, because typically those others were sort of a data dump, and while that might be interesting to you, it's really more interesting, I think, if we're talking back and forth and you're asking me questions, and then I know what's on your mind as well. So that's the new format we're trying, and hopefully we'll see how it goes. So this I just saw, Amanda she's like a medical epidemiology geographer. And what's Amanda's last name? Doolin. So she came up with this. I mean, this is who we are, okay? And just think about that. In the last 10 years, those are the people we have cared for. And they come from all 48 states. We've said that over all 48 continental states. We say that over and over again. But when you see it, it's just so impressive. Our reach is much farther than we had, I think, previously understood. And so that's our platform. When we talk about being a national leader, we already are there. But we need to think of ourselves in that way and think about the areas that would be particularly important for us to lead in. What is it about us that could be instructive to the rest of the nation? And I think it's really rooted in our mission, because we don't talk just about the highest quality of care. You'll see some of our priorities, top decile and things. That's not just about for some people. That's not cherry picking the best paid insurance programs. That's for all people. And if we're able to design a system that can deliver the highest quality, the highest safety, and the most affordability, and we can do that for every person who seeks care from us, we have made a major contribution to solving the problems that we face in this nation around healthcare. So that's our space, I think. This is Virginia Premier membership, and I know it's a little bit hard to see, but let's see, anyways, that number here in Central Virginia, 66,000 patients we cover through Virginia Premier. And then in the western area, 47. But, did you know, 47,000 out in Roanoke. And then over here, the farthest reaches, almost 30,000 people that we coordinate their care. It's our job to make sure that they have good health outcomes through Virginia Premier. You look over at Tidewater, 37,000, and then up in the northern area. So our platform is really across all of Virginia. And whether we do that with direct service and an encounter where the patient comes to our clinic or our hospital, say Community Memorial or our Children's Hospital, or we do that through Virginia Premier because we're about helping them receive the very best care and the very best outcomes that can be achieved for them. It's a tremendous area of influence. And I think increasingly the world is not command and control. It is about your influence that you have in these various areas. And while we would, perhaps in another era, we might have thought, how do we command and control and own all the health systems if we were really aggressive in that way in terms of thinking about growing, that we would have to own, we have to buy and own everything. Maybe a role for us, because of who we uniquely are, is more about influence. And what is the influence that we have, and what can we bring to the table? So these are the 3 priorities that our leadership team has adopted for the coming year, immediate year, but also you'll see this, I'm sure, year to year. There are long-term plans built around this that run out at least 3 to 5 years. And the board, this was presented to our board of directors, and they have endorsed this as appropriate for us. So it has to do with safety, experience, and affordability. So safety for all, the for all, really is partly acknowledging, and I don't know if it's a new phenomenon, but the scale is new, and health systems now across the country are trying to come to terms with this. I know this because I go to meetings of CEOs from all kinds of health systems, and it's about the safety of our providers, of our frontline people, whether it's at the reception check-in, or nurses putting people back in rooms, or nurses and staff in the ICU setting. And we used to think about this as, well, it is part of taking care of people that we understand they'll have these emotional tirades or these outbursts, or they live with this incredible crisis at this moment, and we're here to help them. But it has come to really be, as we learned in one of the town halls a few months ago, 88 incidents of 88 times our staff were assaulted in one of our ICUs in the previous year. It's like, what is that about, okay? How are we going to come to terms with that? And so when we say safety now, we're thinking about that in a broader context than perhaps we had previously thought about it. I think all of you get safety of our patient being first and foremost, and top decile is our goal there, and you'll see that in a minute. Experience is also experience for all. So it's not just enough for our patients to feel well taken care of. They have to see that we are supportive of one another. And I learned this. It was very interesting. Many years ago, we noted in our work at the LCME, which accredits medical schools, that year after year we were reporting that nationally about 18 to 20% of medical students reported being mistreated. And so then we had a discussion about, wait a minute, is that the norm? So we say a school's doing really well if only 15% report mistreatment, and they're doing bad if 25%, that we're saying it's okay year to year for 20%. And then what is that about? What's the source of it? So as we began to explore that, it became clear that it's definitely about how we treat our students, our learners, respectfully, and then one another, right? So we have residents, we have nurses, we have attendings, we have staff who are in every unit. It all is included. But it's about the patient care. And if you think about the times when people have behaved badly, egregious kind of behavior, in front of a patient, what does that do to the patient's faith in us and our ability to take care of them? So it all comes back to providing the very best in patient care, but our care of one another is essential in that. We heard that in our engagement surveys as well, so we'll see a little bit about that. And then affordability, I want to just talk for a moment. We're choosing that term on purpose. So we're not saying cost. Okay, so we talk a lot about reducing our cost, but that is our cost to ourselves. What does it cost us to do a hip replacement? What does it cost us to do a penetrating wound in the ED and run that through the surgical suite to discharge? But let's talk instead about affordability, and that includes cost to us. But as we make headway and reduce our cost of providing this highest quality of care to our patients, how do we pass that along to the patient? Because increasingly, as every one of you know, when you go to the pharmacy and when you pay your copay at the window for your own care and your family care, it's costing you more money than it has ever cost you. And I sat at one of our specialty clinics checking in, and about the same time, the receptionist says to me, that'll be a $40 copay. I hear in the next cubicle, that'll be a $200 copay. So I'm betting that that person who had to write a check or charge $200 had to think a lot harder before he went to the doctor that day than I did. And that's not even thinking about how our incomes compare with one another. And I've gone to the pharmacy and learned that something I used to have a copay of $10 on is now a $118 copay. And it's a generic product. But that was the increase in that the pharmaceutical company was able to effect within 6 months. It's the last time I filled that particular med. So we believe that, again, part of our mission is how do we make cost more affordable to the people we serve. So you'll be seeing more about that, but it's also, I need your help about that as we move forward and ways to think about that. So let's talk for a minute about safety. So it's an interesting environment, and I think every one of you recognize this. Okay, this is not news to you. We work knowing that decisions that we make can either help people or they can really hurt people if we're wrong. And it's a lot of tension. It's a lot of pressure to carry every single day. And I think about working in the neonatal ICU, and we think about the therapeutic index. So you're writing a prescription for an antibiotic for a tiny baby, okay, a teeny tiny baby. And how precise you are with that will determine, do they come out of sepsis or do they die from sepsis? Or do you err on the other side and you prescribe too much and they're deaf? Or they die from renal toxicity. And that margin is minuscule. It's just teeny tiny. So how is it that we can come to work every day understanding that we're walking that edge? That every day we make literally life and death decisions for people. No, you don't need to come into the ED for that, okay? Or, yeah, come into the ED and then, wait 3 hours for maybe something didn't need to be there because all those other people don't need to be there either. How do we balance that? And we do that with our systems. That's what our safety systems are supposed to do for us. So I want to tell you another story about myself. I wrote a prescription as an inpatient senior resident. Okay, I should have known better. I wrote it for an IV drip of MSO4. So MSO4 is the chemical name for morphine sulfate, okay? But these chemical names are very, very similar, as many of the generic and brand names are very, very similar. And it was interpreted by the nurse who took off the order, by the pharmacist who received the order, by the pharmacist who filled it and sent it back up, and by the nurse who hung it as magnesium sulfate. And what happened is this was a patient who was about 16 years old, an adult survivor of a childhood cancer, has now another cancer that's a result of the radiation therapy that allowed her to survive her first cancer. And it's very, very painful. But she's also somebody who complains all the time and really gets on the nerves of the nursing staff and everybody else. She's just incessant in her demands, and she's wailing. You're not treating my pain, I'm in pain. And everybody's thinking, we're running this morphine as fast as we can run it. This is bad behavior, right? We got to manage the young woman's behavior. And I'm thinking, man, this is not feeling good to me, listening to her wail like this. So I look at the bag, and it says magnesium sulfate. Now, it didn't kill her, but it definitely did a lot of harm. It was my mistake. And now we have systems that prevent that. So the Cerner won't let me enter something like that. We still have to check. I mean, think about all the checks that went through. And everybody made the same misinterpretation, but also my fault for being so obscure in how I wrote the order. But our safety systems are designed to prevent those holes from lining up in the Swiss cheese. We're going to have our holes. And we have to make sure that those systems are working and that every one of those checks and balances works every time. So that's why we do our root cause analysis, and we try to take the blame out of it so that we can actually make a better system. It's not about getting rid of people. It's about making a system that prevents any human error from being multiplied over again. So you'll see a big focus on that. And our goal is to be in the top decile. You'll hear some people say the safest hospital in America. Well, there are many people who are striving for that. We're going for the top decile. And we have a plan to take us forward. and it involves everyone's participation. The other thing I want you to think about is that this applies not just to people who write prescriptions or fill prescriptions or distribute meds. When we think about people in housekeeping and they are cleaning a room, they know that they're preparing a room for the next patient, and that their ability to clean that room could prevent propagation of some of the things that end up killing people or prolonging their hospital stay or causing serious disability. We recently had one of our star recognition employees, because she saw something that indicated that maybe this room had had C. diff, but she wasn't given the proper supplies to clean that. So she took it on herself to go and find the right cleaning supplies to clean that room. Now that's an example of a star employee, right? She's thinking on her feet, she's using her head. She doesn't just accept what's given to her. She's recognizing something's a little off and I need to do something about that. And she did, so that was great. But what we're trying to do is build systems so that, one, people think like that on their feet. It's not people doing what they're told to do. It's following what they know to be the right thing and pursuing that. And second, that we do have the right supplies to people almost every time. And when we don't, we got to figure out why. And what was that chain of events that caused that? So safety involves every single person in our organization, and is important to every one of us. Experience. Patients have choices. So even our Medicaid patients have choices now, okay? So this is not like we're the only place people can go if they have Medicaid. We're still probably the only place people can go if they have no address, if they have no insurance at all. So we do have that. But they're entitled to the best experience that we can possibly provide. As you all know, it's partly why everybody's here instead of working someplace else where you'd have easier parking. But we think about this also, our goal is top decile here. So we really don't want to be the kind of place that hangs about average in safety and experience. We want to be the place that people choose to come because we are the best. They think we're the best because that's the glow of the academic center, as surveys and research tells us. People still think that the very best care, the general public, is given at places where they have level 1 trauma centers and where they have cancer research going on and clinical trials and cutting edge things happening in the OR suites. So it doesn't matter what's wrong with it. I mean, I feel that way. I want to go, whatever my problem is, to the place that's right at that edge, that really you're around people who are wanting to improve what they do every single day. But we got to make sure we do that. We got to make sure we give people a good experience with that. Because it turns out that's been very expensive to do all that stuff. And we're now working on bringing that down. But we don't want people to choose between what could be cutting edge and exciting and a really vibrant atmosphere in which to be cared for versus how do they spend their copay? How do they spend their co-insurance? How do they think about their deductible? And then that's where we come to affordability. This is kind of a sobering fact here when we think about biggest cause of bankruptcy is due to medical bills. So our revenue cycle team has been doing a lot of work with our legal team and our finance office. How can we address this issue of surprise medical bills, et cetera? It's not blaming, okay? Most of what you read in the paper is, well, they should have known it because it was in their insurance policy. Have you ever read your own insurance policy? I don't understand mine. I mean, so I'm wondering, like, what degree would be required to understand this stuff? My son is on the exchange, but I have to do the homework for him because he won't do it, and he gets frustrated. But I spent 3 hours trying to figure out what would be the best plan for him because he travels state to state in his work, and he has horrific systemic allergic reactions, life-threatening allergic reactions to different things like poison ivy. And he works in landscaping, like, yeah, your children can be risk takers in many ways, you know? It's like, ah. So, but I'm thinking like 3 hours. And there was a moment when I thought we had missed a payment. And that was a deep-rooted panic for me, that his insurance would be cut off. And I couldn't get an answer at Blue Cross of Louisiana. I couldn't connect with a person. There was no article that addressed my concern from which I could learn, although I was referred to countless such things. So I had to wait till Monday. So in the meantime, I go, okay, we screwed up. We missed a payment. Okay. What are the options now? Not good, people, I'm telling you. Not good. Every single option to get insurance outside the exchange as an average person, pre-existing conditions, every single one of them. No pregnancy coverage, every single one of them. No prenatal care, every single one of them. It's like, oh, this is how we start. And then it gets worse from there. Okay? So this is a serious, serious problem when we talk about what people face day to day in their lives. My daughter has multiple sclerosis. Oh, by the way, my family is very comfortable with me talking about this stuff. I asked their permission at one point. They said yes, because I actually gave a talk about it in front of 4,000 people, and they were sitting in the front row, so I had to make sure they were comfortable with it. But her latest medication, she had to switch to an IV infusion therapy, and because she had side effects with the other med, and the cost is over $100,000 per year. And so pre-existing conditions is now really important in my family. And what kind of insurance coverage she has is really important to her. She has really good coverage. She pays out of pocket about, well, at the 6-month point last year was $7,000 out of pocket at a 6-month interval. And that was with good insurance. Okay, so it's just, it's like a new normal. As a family, you get used to this stuff and how to work through it. And then in this Penny, you'll really identify with this. She also can't have her infusion at the hospital where she's cared for, in their infusion center. She has to go to the infusion center that her insurance company has chosen. So she writes me from that infusion center, it's filthy. They have paper records, and they're like lying all over the place, and I can read about everybody all around me. I said, you take me pictures, and I am sending them to the insurance company. It's like, don't make me mad as a mom. That's like really cuts to the core. So, but, like I know how to deal with this stuff. And I have people like Denise and Cheryl who help me deal with this stuff with other parts of my family. But how many people can you have who work on your behalf in that way? Like, most people have no such knowledge or avenue of support. So we have to make this issue better for people. The other part that you may not realize is now strong, full force, almost every insurance on the exchange as well as in our own sort of Cadillac products is co-insurance. So that means that you pay your copay and you have your deductible. But when you go for your episode of care, urgent care, ED, hospitalization, there'll be a % of that you're responsible for regardless. Okay. So, for example, my son, his is pretty good because, by the way, that plan costs $770 a month to get out of state, to get coverage in multiple states. But his co-insurance is only 10%. So his last visit to an emergency department for an allergic reaction was something like $1,200. So in addition to the copay, he had to pay $120. Is that right, $120? Yeah, thanks. I'm not the CFO, so don't worry about it. So these are just layers on layers that people don't even realize they have, right? They don't even know. These are the surprise medical bills or this group of doctors is not in plan, but this hospital is. How do you expect people to know that stuff? Like, who would think that? So we've got to tackle this in a serious way, and you'll see a lot of efforts to do that. This I just go back to, we do have humility in our work. Our mission requires that. People wouldn't come here to work if they did not feel a certain sense of the importance of service to others. And yet, we can still be very proud of the work that we do as team members, and proud of the work that you see around you being done by your colleagues and your compatriots in all of this work. So I'm going to end there and allow you to encourage you to ask whatever questions you might have.
And if you can let us bring the mic to you so people on the screen can hear the questions that are being asked.
Yeah. Yes.
So first of all, thanks for the chance to do this. I've been publicly critical at times when I think things have not worked well operationally. So I should be publicly appreciative of the chance to have a conversation. Thanks. So thanks very much. Yeah. Yeah. So on the affordability piece, which I think is really, really interesting, it's been said that one of the things that would make healthcare more affordable across the board is if we change how we collectively pay for healthcare, and specifically how we may pay for physicians, right? Not do volume-based sort of payment, and yet for a long time that's been how we've been successful here historically. It has been my impression that while we hear a lot about that, it has not actually happened, and it's certainly not happened in Virginia yet. And so I'm wondering if you can comment with your crystal ball at all on whether you see that changing at some point to actually change how we get reimbursed collectively.
Very important question, because all of our financial forecasting is dependent on us getting that right or building in enough flexibility to move in both directions. So it's really the difference between being paid for an encounter. So if you come to see me in clinic, you'll be charged this much for the physician services and this much for the facility. Maybe separate, maybe the same. Or is that visit to clinic for your heart condition going to be part of a package deal that your congestive heart failure will result in an available payment of XYZ, and it'll be based on the quality of your outcome. So if you have to be readmitted, ding, some of that goes off. If you have to have more days of disability, ding. But you smooth sailing through diagnosis, treatment, one of the better outcomes, better payment. You get a little extra for that one. So that's a value-based payment, right? So it's very interesting that while the insurance companies have not embraced this, kind of plus minus, CMS, which pays Medicaid and Medicare, are all over this. Okay, they want this. They are insisting on this. They are requiring this of us. And guess what? When they say Medicare for all, that is CMS. Okay, and so I think that, and even in some of our discussions now, we actually would prefer the value-based approach. It allows us to plan services across the whole continuum. It means we've got to beef up in some of the areas like aftercare. We would really have to get better at that, have more capacity and capability in that than we currently have. But we would prefer that to the encounter-based, because the encounter-based is frustrating in that you might see me, but then I come back to see you when I'm not better from what you did, but you don't ever get to know that because it's the same system, but I'm going to see a different doctor because that side effect is in a different organ system or something. So we think that we could actually manage control a lot better if we had more input into the various levels of care required for that condition, and you get that through value-based payments. So as we look through our forecasting, then we have to, like right now, we're running scenarios. Every health system in the country has done this, I would expect, but everyone I've ever talked to. We've all done the scenario on Medicare for all. What does that mean? How much would that cost us? We would pretty much have to take out at least another, with our vision by design, our value and efficiency work, we're taking out, and we're doing very well with that, by the way, to date, $350 million over 3 years, right? We would have to do that again, another 350, and some people say another 350 to absorb Medicare for all. So we have to be prepared to go in either direction. We prefer the value-based. We think even if we don't go to Medicare for all, so a compromise to that, maybe anybody who wants Medicare can choose that, which would be a whole lot of people as it seems to be shaping up. That predictability, that sense that it'll always be there, won't change year to year what's covered, is very attractive to people, even if it's maybe less than what they might get through their employer. What people are getting through their employer is now, like for my daughter, she really can't change jobs unless she gets an equally good insurance component to her job. And she lives in Los Angeles, and there are a lot of job opportunities, but there are also a lot of companies that offer no benefits at all. Great salaries, no benefits. So if somebody, like she might say, gee, I could be in Medicare, and I wouldn't have to deal with that. I'd have a lot more mobility in my professional life. I don't know if that's true or not, but it might occur to her. So we're running those scenarios to understand the impact of changes in how healthcare is structured. But we actually are hoping that we see this pendulum swing towards bundled packages and quality payments. Yes.
So I used to be in the call center, and I have heard something about some improvements over there, and that is very much our front door. So can you tell us anything exciting about it?
So I want to tell you a little story about that, okay? So, I would say that 99% of the complaints that come to me as the CEO or come to the president of the university, and he always sends them to me, and that come to our board of directors, and then they bring them to me. 99% of them are about access to care. I can't get in, nobody called me back, I can't get an appointment. Okay. So we're talking about this, like among clinic directors, department chairs, all this stuff. Oh my gosh, the call center, right? Call center's not good. It's making things worse, okay? All right, let's go see what happens in the call center. And we had a couple of physician leaders go see the call center, right? They saw what happens when you answer the phone and you have to look through 40 different templates before you can schedule that appointment. So how long does it take? How long does that person have to be on hold while you go through 40 different templates to find the right one that fits the exact need of the person who's calling you, right? It's not only this specialty or this clinic, but what kind of appointment within that whole structure, right? So that was kind of an eye-opener, right? So, okay, let's take it for what it is in its complexity, right? And let's figure out, can we do something to move that needle? And they did what they call a 10-week sprint, where they set very specific goals, and they had real improvement there, significant improvement. And the call center staff were like excited to be doing this, because they don't like this either. Like, it's not a good feeling when you have to put somebody on hold for 15 minutes while you're trying to figure something out. It's an example of, you make my job harder than it needs to be, right? So those are the things we need to hear. What is making your job harder than it should be, so we can do blocking and tackling, get rid of that. So great gains were made. Now, what we're looking at now is how do we scale that up, right? So what allowed improvements to be made in seconds to answer the phone, wait time, like on hold time, and then time to actually place the call to the appointments made. So how do we make that happen across the board for every call that comes in to the center? So we're working on that. So yes, a lot of good effort on the part of the people who work in the call center to help with that. And I think a lot of experience now that, when we put these problems out on the table and we begin to hash through them, it's pretty quickly known that it's not as simple as maybe we thought it was. And it's probably why it got to be so hard in the first place, because all these workarounds, people were trying to patch it up here or there.
So with that, I feel like I've seen several examples of where we make things harder than maybe they need to be. How do you plan on sort of deliberately prioritizing those and going through those so that we're not trying to tackle all of them all at the same time?
So that's an important question I think we're grappling with. The chairs decided, in the physician practice plan, decided that the number one priority would be access. So those kinds of problems that are making it hard for people to have access. Sometimes it's a matter of we don't have enough people in this particular specialty. Sometimes the templates need to be changed. Sometimes it's a matter of how hours are scheduled for availability. We do have to look at the world from the point of view of the people we serve. And that's a hard thing for medicine. So I presented papers around, I went to different parts of the world sometimes in my career. I had this meeting, I had that. I wanted to take a vacation with my family, right? Pretty routinely, we just cancel clinics. Well, we don't think about it that way anymore. I mean, if you think about yourself, you don't want that appointment you've waited for to be canceled out from under you. You don't want to show up and be told, oh, gee, there was a mistake. Like, that doctor's not here today. But we've rescheduled you for next week. Well, you can't come next week because you got this day off. You didn't get the day off next week. I mean, this isn't working for people, right? So how are we going to think about the working family? Two parents work in most families, or whether you have one or two parents, they're working. And so how often can they take a day off? So we got to do evening hours. We got to do weekend hours. But we also have to have a life of our own as providers. So how do we organize this so that we don't have everybody doing double duty to provide these extra hours? And we're starting with the outpatient clinics and starting with, I think, a couple clinics at a time to try to model what works. But we really need, Tom Yackel and I do these listening sessions. And in those, we really do listen. And we start out saying, we've heard that we make it hard to do your job. So tell us what is making it hard. And we listen for an hour. And then we start thinking of ways immediately to help. Every once in a while we can say, oh, okay, I got a fix for that one. Like, I can help you tomorrow. Because usually these are in the evening. I can get you help tomorrow. But sometimes it's like, okay, got to think about that one. And then sometimes it's like one of the surgeons said that she was really, she works on neonates, okay? And she said that she was really happy to see that she didn't have to do the workman's comp compliance training anymore. That was no longer mandatory for her. It was a couple hours, I think. Now, the social worker in the neonatal unit probably should do the workman's comp compliance training, because that would be part of his or her toolkit, right? It's got to be talking to families about resources that you have, and workman's comp could well be one of those. But, the surgeon, probably not so much. So, thankfully, when she said this, I could say that we realized we've done we've added on compliance training, and we're not exactly sure who gets to decide what's mandatory. It's kind of like each person in their own area of compliance gets to say, this should be mandatory, and then it is. And so nobody has, until recently, looked across the whole experience and how, not just the number of hours, but are they useful to people? So we all have to be trained for the experience that someone shows up with a weapon and is threatening. Okay, that could happen to any of us anywhere. But we don't all have to be trained on workman's comp. So we're going through that and trying to remove that, at least that obstacle. There's very acute awareness that our staff are working long hours, and that is very draining, that you can only do that so long. That is not sustainable as a strategy. That people are working late in clinic, and then they go home with their family, and then they go back online to finish their medical records. That is also not sustainable. But I think you've heard me say this, or you may have heard me say this before, but we can't tell people no emails, no work after 9 p.m., because we don't have a way to relieve them and allow them to do that work before 9 p.m. So until we can make it easier for people to maintain their record as the usual course of their workday without sacrificing the access issue, we're not going to be able to tell people you can't do this or that. So this is where the obstacles sometimes are very complicated. It has to do with the medical record, how easy or hard is that to use? How easy or hard is it to change to a whole different one? Would it be any better? All of these conversations are linked, but they're in process. We are having these conversations. So we are trying to prioritize and access and then experience. So if we clearly see there's a place where people have repeatedly a bad experience when they show up, we'll be trying to prioritize that too.
Hi, Dr. Rapley. My name is Nathan Cunningham. I'm the manager of patient experience in the Department of Patient-Centered Services. Yeah, no, thank you. Yeah, and we take it with a smile. So I'm very pleased to see experience as one of the 3 top priorities, and I hope that's a perennial priority moving forward. And also on that chart was team member experience, and we know the symbiotic relationship between patient experience and team member experience. But specific to this point, there is a subset of team member patient experience, team members that are our own patients and their family members. And increasingly so over the past year, we've seen a rise in those complaints from that subset. People unable to access their own appointments for their family, basic radiology examinations, diagnostic imaging that should be able to take same day that are put out 12 days, 13 days. And I know we have a front door issue. We have a broken front door for access, but unfortunately our back door is also starting to bottleneck as well. And I'm wondering if there's something that we can do for our team members. There used to be a gold line. There used to be something else. In this room, less than 50 people, there's more than 4 people in this room have had to come to me to try to get some backdoor access for themselves or family members. So if there's 4 of 50 in this room, imagine what the larger population would be. So I'm just wondering if we've talked about that aspect of our team member engagement and team member experience and anything that can potentially come back down the road to address that.
No, but I think I don't have an answer for you today, except that I've thought about this. So, many of you have been part of taking care of my dad, who's a frequent flyer here at VCU Health. And Denise and Cheryl have been really helpful in that for me. And yet, we could have 50 people on that team. And then how would we have to staff, say, the neurology clinic to deal with each one of those 50 people calling to get special access? Like, we'd have to have at least an FTE who was open and ready and didn't have anybody scheduled. So we are thinking about that. But let's back up from the logistics of how that would work, which seems so daunting, right? Should we have some kind of policy about that, about how we would expect to deal with one of our own people who come? How would we define that? Would we prioritize them over other people? We've been reluctant to have any sort of tiers of care because that sends a bad message to the people we serve. But I agree with you. It's really disconcerting and very troubling when somebody says, I wanted to come to VCU for my health care, but I was told, like, you should probably go somewhere else because we can't get you an appointment for months and months. So we gotta, thank you for bringing that up. I think that is an important part of how we think through this, because we have more than 12,000 employees. I mean, sometimes we say 15,000, depends on who you count. So many people are paid from one, either VCU or VCU Health, but working on the same kinds of issues. You know, that's a lot of people. We bring 900 million in payroll into the Richmond region every year. Payroll and benefits. That's a lot of people. That touches a lot of people. So, yeah, it would be very important, I think, for us to think about this. Our goal is for everyone. And I'm a little bit reluctant to set up these special tiers. But I do think it's worth vetting and talking about how should we approach these. And I think it's good that our people are bringing these things forward. It's very awkward when you're part of the place to be complaining about it, because you don't want to start like everybody gets in trouble because you complained about how you were treated when you went here or there, or you don't know what you're setting in motion, and maybe just be quiet about it. But we need to know, because if it's happening to the people we know, it's happening to a lot more people than that. And so this, in the same way that we need to remove the things that make it hard for all of you to do your job, we need to remove the things that make it hard to get cared for at VCU Health. And there are many of those which may seem beyond our control, but as we examine them, there are ways for us to make headway there. So thank you, Nathan, for bringing that up.
So I've been losing a lot of sleep over this affordability question, and it's one that, so we care for patients regardless of their ability to pay, which is, I think, one of the reasons many of us want to be a part of this organization. And that's an attitude that's not always shared with community hospitals and community providers. And because of that, we're seeing our payer mix shift increasingly towards governmental lines of business, which again puts pressure on our finances because the reimbursement levels are dramatically lower. So meanwhile, I am feeling, in my role, tremendous pressure from commercial payers to pay less. They are pushing to drive down our reimbursement at a much faster pace than we're willing to or able to manage it. And if we're not able to keep pace, they're very quick to redirect that business, as you commented earlier about your daughter, to a lower cost provider in their network. So we start to lose volume, which again, it becomes a pressure on our finances. So I guess part of what I'm hearing is we are very fortunate that there is demand, that we have patients who are lining up trying to get in here. That is a gift that we need to treat very carefully and try to find a way to open up those doors and get those patients in here because they want to come. And we need that balanced mix of patients accessing our health system to keep the financial balance sheets working, and patients who are insured have choices and can go elsewhere. If we can't get them in within a reasonable time frame, they will quickly make an appointment somewhere else. So it worries me. I lose sleep over it, and I don't know if we can bring our costs down fast enough to maintain our margins as our reimbursements continue to decline.
The whole reason we struck out on this path for value and efficiency a couple of years ago was in anticipation of this. It was clear that insurance companies were going to be lowering their payments, that the government was steadily, I mean, there's just, decades of every year they pick a few specialty areas or a few procedures, boom, we're just not going to pay that. I mean, I remember when I was interim chair pediatrics, and I was less experienced as an administrator then, and I probably took a more kind of black and white position than I had to. I just didn't understand how many options might be available to me. But I had to tell the pediatric cardiologist that I couldn't pay her salary anymore because the reimbursement for her number one procedure, which was ultrasound, was cut to less than half. It was about 40% of what it had been from one year to the next. Okay, so boom, right? And so she went to work for the competitor, right, in another city. They were willing to pay her more than she could generate because she began to funnel off the referrals, right? And she sent them to another city. So lots of repercussions of our issues around those payments coming down. Our supplemental payments, when I came, was about 360 some million a year that we got that year in 2016 from the General Assembly. This year, about 120. So like that's a lot of margin there that we don't have to work with anymore. And that's going to continue. So that we saw that coming, and it's why we set out a 10% reduction, 350 million, 100 the first year, 150 the second year, and 100 the third year. So we're 3/4 through the second year. We're on track, but it is hard. It is blood, sweat, and tears to get that. And then we have a lot of really good ideas have been put forward already for next year's 100. So that's very encouraging, actually. It's in excess. But even doing that, we're just kind of breaking even, a little bit more than breaking even. The chairs came up with a phrase that I thought was very powerful. It's margin for mission. You know, usually you say if you don't have a margin, you can't have a mission. But let's think about it that we're generating a margin so that we can support our mission to provide the best care for all. And then how are we going to do that? We had this conversation this morning. I generally sleep at night. There aren't very many things that keep me up at night because I think we have these amazing people we work with, and we face really horrible stuff every day, and we figure out how to do the right thing and the best thing. But man, it bothers me about where we're going to put this increase in volume in inpatient care. And I look at the stats. For the last 2 weeks, we've had 1 to 3 or 4 of our main units 100% or more capacity. So you might think, whoa, that's so great. No, that is so bad. Because that means if you got somebody coming in with a coronary problem and you're the Pauley Heart Center, you don't want to be shipping them to bones to core and diversion. I mean, come on. That should be our patient, right? No beds. They're like 115% capacity. What are we going to do with them? So this is a serious problem. It's partly our own making, okay? So we put up the new children's pavilion. Man, volume increased 40% in 2 years. We did not expect that. Patient satisfaction went from 60-some% top box endorsement, 90-some%. It's like, okay, so as one mom said, well, I came to see like what it was like. I'm staying, I'm coming back. Lots of people doing that, and some word of mouth. But all of those outpatient visits generate inpatient activity, and we're not prepared to really handle that until 2026 or 2028. That is a long time to be holding on. And if we divert patients through all of that time, we're not going to have them anymore. They won't be our patients anymore. So this is a serious issue we have. We think the same thing will happen when we open our new adult outpatient facility. It's going to be gorgeous. And I used to think, like, how superficial, you know, it's the paint, it's the decor, like, who cares? But it's not that. It's really the lighting, it's the workflow, it's the noise level. It's all the things that make you feel more comfortable in the space. This is in our new spaces. And confidence because it's clean. Now, our spaces are clean. I mean, you could, you know, eat your food off the floor in some of our spaces. But they don't look that good. They don't look that clean because they're old. And after 50 and 60 years, you have stains. And when you replace it, it gets stained. So, yes, we have to work on that throughput, so how long we keep people. Understanding that some of those issues that seemed impossible to fix, like what do you do with a person from the correction system who can't go back to prison because there's nobody there to do the wound care. But if they were not in corrections, they could probably go home and have home health care. How do you fix that one, right? Well, that's not impossible. And we got to be tackling that kind of thing, getting the home care set up as a person's admitted, as many of you have been pressured to do. And it seems like, well, isn't that out of whack? Isn't that the cart before the horse? Not really. If you can anticipate home care, then you need to be setting it up, even perhaps before the admission. So there are things we need to think about from all those directions, and we're seriously challenged in that, especially as we ramp up our marketing, our public relations work, and our children's hospital is bringing a huge amount of attention to us. Our Massey Cancer Center work is bringing a huge amount of attention. Our Pauli Hart Center, our new director, and his love of being out in the public schools and community organizations and helping people understand about not just their heart, but healthcare in general. This all generates a lot of interest in us. And we need to have places to accommodate people. So that's partly why access is such a focus point for us. We're almost at, is it 2? Is that our end?
3 minutes left.
Okay, so we can take another question. Oh, okay.
Hi, Dr. Rapley. Amanda Patterson, radiation oncology. So we've talked about access, and we definitely feel that in oncology, where patients call to get appointments and may not have them available for 2 to 3 weeks. We know that these patients are emergent, so 2 to 3 weeks isn't really acceptable, and I don't think it's acceptable from an organizational standpoint. I know there's work being done, and we're trying to better that. Same thing with the financial affordability situation. Oncology, our patients come in, they're typically sick. They're seeing surgical oncology, radiation oncology, medical oncology. It's very expensive for them. Those that have insurance, it's expensive. Those that are underinsured, it can cause bankruptcy. Those that don't even have the opportunity to use the marketplace because they make just a little bit too much, and they can buy their own groceries and pay for their housing, so they don't they don't qualify for Medicaid or that type of assistance either. So they really have nothing, and so we know these. And a lot of them do lose their jobs. So we know these things. And I know that there are plans to work on them. So I'm looking to you to offer me a little bit of, a little coaching on, I'm on the front lines every day, and these patients, I'm hearing from them calling, I'm hearing the other providers calling saying, I can't get an appointment in this department. I have that patient sitting in front of me who doesn't qualify for Medicaid or indigent care, doesn't qualify for the marketplace. Their care is going to cost $250,000, $500,000, and they're asking themselves, is it worth it? At stage 4, I may or may not, the end result may not be worth this. I don't want to leave this financial burden. In my mind, I'm thinking, as an organization, we're going to have, in the future, I'm not going to be in this position because there's going to be something in place that patients have, an option or something. But today, and for the last 6 months and last year, I don't have those tools. And so what can you offer, what insight can you offer for those folks that are in those positions to say, I know there's a plan, I know it's one of our top priorities, but just to get by day, what can you offer or recommend?
Alluded to it a little bit a while ago, to prevent people from going into bankruptcy. because of their medical bill at VCU. So it was very difficult to work through the legal aspects of that. You can't, when I started in this profession, I could see a patient and I could say, I'm not going to charge you today. And I would write NC on the encounter form, and the patient wouldn't be charged. And then about midway through my career, CMS considered that fraud. And so I was told that the only way I can not charge my patient for that encounter is if they actually go to Medicaid, apply for Medicaid, get turned down, and then bring us a letter that says you're denied Medicaid. And then I can write no charge or reduced charge. Otherwise, it's fraud, as far as the government is concerned, that I would allow you to get off with no pay, but I would require the government to pay for you, kind of thing. So that was a huge change in the culture of medicine. That was huge. And so now, what we will have as of May 1st, it's been worked through all the legal ramifications of it, but it'll be an adjustment in what is owed to us based on the income of the family. So it is not, here's your bill for $200,000. Would you like to set up monthly payments? It is, because, honestly, some of those monthly payments are $10 a month. Okay, that's never going to be paid off, but the person carries that, right? That responsibility, and it's there on their credit and all. So we're going to be saying, even though this is a loss to us, we have to look at the balance of this over time. How much of it a loss? How much can we afford to absorb? But it's part of trying to make it more affordable for people, so that as they look at this medical bill, we're going to make a decision about what do they actually owe us in terms of their ability to pay, and then work from there. It's still going to be a hefty bill, but it won't be that kind of crippling, can never get out from under, and the thing that drives a family to bankruptcy. That will happen so that's like, less than 2 weeks away. That's a week or so away that will be official, and you'll all hear about it. But so I would say right now, and for example, we're the only place that does CAR T cell therapy for certain lymphoma, certain tumors. You can get it at NIH, you can get it in Philadelphia, you can get it in Atlanta. Other than that, we're it for this whole region. Okay, it costs about $300,000 or $400,000 a year. Nobody pays for it. Maybe the insurance companies are just now agreeing to talk about whether or not they'd pay a portion of it. We've been doing that, and we've been eating that, basically. But again, we don't want that patient to not come because they think they can't ever come close to assuming that kind of bill. And we are now providing that therapy with Carilion Health System to people who live in the most remote areas of Virginia, out in the western part of the state. They would never have an opportunity to have that kind of therapy. One, they're not close to it, but two, there's some very impoverished areas there. And it's like, this is what we're about. This is what we're supposed to be doing. So we got to figure out a way to do that. I would say that people just need to be told to come, and we'll figure it out. It's very, very difficult, and I think one of the most disturbing things I ever heard in my career was at graduation back at Michigan State, and one of the students was addressing the student body. And she was a young woman from Los Angeles. And she went into medical school because her mother died of breast cancer. So she was determined that she would be a doctor, and she would figure out she'd be part of research and improving lives of women with breast cancer. And she was in her first and second year of medical school when she figured out her mother died of a treatable form of breast cancer. Absolutely treatable, but had no access to care, had no insurance. So just was turned down from multiple places. In the family's mind, she died of breast cancer. But she really, what this young woman learned is that she died of denial of care. And it's like, you listen to this, and so now this young woman is equally determined. You know, she's graduating from med school, and part of her life's work, at least at the point of graduation, was how do we bring some social justice to the healthcare system. We will be part of that too, and apologize to every one of you who have to deal with that frontline issue. I know that our people checking patients in and out invariably have people who walk away and say, oh, okay, I can't pay you $200 for the copay. Our people in the ED are facing this all the time. But how do we, how do we deal with this day to day? It's part of the demoralization that all of us experience in the work that we do. I think that constant reminders that this is in front of some of you more, so it's not in front of me every day. It's in front of me when somebody complains about it, or I read about it in the newspaper, and I'm thinking, oh my God, I hope that wasn't VCU Health. It's a little after the fact, right? We've got to be more active up front, which we're doing now. We're kind of getting ahead of that. And Steve was just pointing out that he was on some committees that lets him know that radiation oncology and surgical oncology are up for, and medical oncology up for some in new ways of dealing with that this week. So maybe more to come on that, I hope so, for you, but for all of us. It's a worthy problem to tackle, and nobody else is going to do it. And that's what I love about this place and our unique opportunity to contribute, is that we take on problems nobody else will deal with. Thank you.